So what is insomnia? I just want to make sure we're all on the same page. It's subjective. It's up to you to determine whether you have insomnia or not. If you sleep 6 hours and the next day you wake up and you're totally refreshed, you don't have insomnia. So insomnia is not the number of hours you sleep is the right number or the wrong number. It's what suits you. Some people like 9 hours of sleep and they feel best with 9 hours. Other people, 6.5, 7 hours of sleep. It's when you feel like you can't get to sleep or you can't stay asleep and your mind is racing and you're worried about the next day and you think it's all going to fall apart. That's characteristic of insomnia. Now, does it happen regularly, almost every night? And does it happen for weeks or months? Then we talk about insomnia disorder. So everybody's comfortable with when you visit your doctor and your doctor asks you about your sleep and it sounds like you have insomnia, it really is because you're feeling distressed the next day because of your sleep problems. Some people have 8 hours of sleep and feel distressed the next day because they don't have enough sleep. You've heard this 8-hour thing. It's not a rule. It's not a rule. Most people say a healthy amount of sleep is somewhere between 7 and 9 hours, but I just talked to somebody who says I do fine on 6 hours. And so I'm not going to say you have insomnia because of a number. It's really about the distress you feel the next day. Why does insomnia happen and what keeps it going? So this chronic insomnia, this insomnia disorder, what keeps it going? So we talk about something that maybe you heard about when you learned about Pavlov and his dogs, learned associations. So who here goes to the dentist and starts to feel tense when you go? That's a learned association. When our doorbell rings at home, my dog barks so loud, I don't like having visitors. I get tense when the doorbell rings, even if the dog isn't barking. It's a learned association. And this is what happens when people have insomnia. They start to get tense because they're thinking, is tonight going to be like last night or the night before or the night before? Their mindset is not ready for a good night's sleep. And if your mindset's not ready, you're probably physically making yourself tense. So your body's not ready for a good night's sleep. These are the things that we can address so that you can get a good night's sleep. So we're going to talk a little bit about that. What people do to keep it going, see that little cycle that keeps insomnia going is you go to bed when you're not ready to sleep, just like I mentioned. And then you lie in bed and your mind races and you get this bad association with your bedroom and your bed. The next day you wake up feeling fatigued, not ready to take on the day. You start canceling appointments, socializing. You drink more coffee. Maybe you have a nap. Coffee and a nap steal your opportunity for having a good sleep the next night. Some people go to bed early going, tonight I'm going to get a good night's sleep. And what do? They reinforce that association of being in bed and not being able to fall asleep because they're not ready to fall asleep. They don't have the sleep pressure to fall asleep. So let me just do something really quick about the biology of sleep. We have two biorhythms that control our sleep and daytime cycles. This is one of them, and this one is relatively important for us to talk about. This is your sleep pressure cycle. The minute you wake up to the minute you fall asleep, you're building sleep pressure over the day. There's ways to steal that sleep pressure. One is caffeine. So when our brain is very active during the day, we're using energy in our brain, and we're making this chemical called adenosine. Adenosine actually is one of the chemicals that helps us be ready for sleep. Caffeine just happens to be a complete blocker of adenosine. So biologically, there's a reason why caffeine keeps us awake. We can also have our adenosine levels affected by a nap. You can steal your sleep pressure by napping part of your day away. The later the nap, the more likely it is that you're not going to have enough sleep pressure or sleep drive to fall asleep at night. Does anybody watch TV at night, kind of fall asleep a little bit? Oh, this show's back on. I like this show. Watch a little bit, fall asleep again. You're stealing your sleep pressure. Can you get up and stop watching TV and do something else until it's your set bedtime? If you cannot fall asleep in front of the TV in the evenings, you will have a better sleep associated. If you go to bed too early, like I said, you may not be where you need to be in terms of your readiness to fall asleep. So very often we tell people, if your set bedtime is what, 10 o'clock, but you're not thinking, I'm going to fall asleep at 10 o'clock or 10:05 or 10:10 after I turn the lights out, stay up, do other things until you feel ready to fall asleep. So these are some of the things that are really important for us to change the things that are maladaptive that are keeping us from getting back to the habit of liking our bed in our bedroom. Okay. So the treatment that's recommended for insomnia is not sleeping pills. The recommended treatment is a behavioral approach and a psychological approach, and I'll introduce you to that in a minute. The other causes of sleep problems are listed here. Now, this is not all of them, but these are the common ones, and I think Sam's going to talk maybe a little bit about, when people come into a family doctor's office, the family doctor has to think about all of these different contributions. The most important thing I can say today is each of them has a treatment that's recommended. We don't treat all of these sleep disorders with one treatment. They all have their own treatment. So if you have two problems like sleep apnea and insomnia, you treat the sleep apnea with its optimal treatment, and you treat this insomnia with its optimal treatment, two separate treatment approaches. What's the rate of insomnia? It's high. That's why this is a relatively popular subject. There's a lot of people lying in bed lonely at night feeling like they're the only ones. Well, you've probably got lots of other people out there with the exact same thoughts that you're having. So right now, 10 to 15% of people across Canada have chronic insomnia, where they've had this issue for months or years. It's higher in women, about 40% or 50% more in women. And if you look around the room, you can see there's a bit of an imbalance in the presentation of sexes. Older adults have it a bit more. It tends to increase in people a little younger than me, and then stay a little higher for the rest of our years. Now, we do have changes to our biology that make sleep a little bit more fragmented or broken up. That's normal. If you wake up in the night 2 or 3 times, often to go to the bathroom like me, that's not abnormal. That doesn't mean you have insomnia. But if you wake up 2 or 3 times and can't get back to sleep for 45 minutes or an hour, that's where we have an issue that we would probably want to help you with, especially if it's causing next day distress. If you have other health issues, pain, for example, diabetes, cardiovascular conditions, depression, anxiety, post-traumatic stress disorder, the risk of insomnia goes up quite a bit more. All right. Insomnia is not just a next day problem. You can think of insomnia as part of an opportunity to improve your overall health. If you can manage your insomnia well, you can reduce your risk of depression or your experience of depression or anxiety or diabetes or improve your cardiovascular health. So we take insomnia treatment seriously because it can have benefits for your other health concerns, whether it's mental health concerns or physical health concerns. So question for everybody here, you ready? What's the answer? What do the experts recommend? Stay in your bed longer? Use melatonin? Put your hand up. No, don't have to tell me. But I bet you a bunch of people here are using melatonin. Reduce the temperature of your bedroom. Sleep. Hey, those weighted blankets are evidence-based treatments for, are they not? Maybe, no? Okay. Is it all of the above or is it none of the above? It is none of the above. There are basically 2 main approaches: pharmacology, medication, or psychology and behavior. And as I already said, it is CBT-I, cognitive behavioral therapy, for insomnia. The for insomnia is really important to add because there's different types of cognitive behavioral therapy. The for insomnia is the recommended, worldwide recommended first-line treatment of chronic insomnia. Put your hand up if you'd heard of CBT-I before you heard about this event. That's good. So looked about 20–30%, I would say, had heard of it. I want everybody to know about it and become familiar with it and interested in it by the end of today. So the guidelines from the US, Europe, and Canada all say the same thing. First-line therapy for insomnia, especially chronic insomnia, is cognitive behavioral therapy. Second-line therapy after CBT-I has been demonstrated not to work is a pharmacological intervention. Think about that. Have you tried CBT-I and that didn't work out, so then you went to pharmacology, or is it usually the other way around? It's usually the other way around. So we're working on trying to make that change. It's been well known that we're overusing sedatives in Canada and elsewhere in the world. So Choosing Wisely Canada has made it clear, don't use benzodiazepines or other sedative hypnotics in older adults as a first choice for the treatment of insomnia, agitation, or delirium. But this is from Alberta. This is the use of prescription sedatives. As you can see, it climbs with age. And it looks like fake data. Doesn't it? Like, it's so well graphed. It looks like fake data, and it's not fake data. And this is what we see across Canada and in other places, that the older you are, the higher rate of using sedatives. And I just showed you, don't use sedatives, right? It says don't, and then we see this. We're using too many sedatives in older adults. All right, we do have an issue in Canada, especially in Atlantic Canada, with overuse of sedatives. See this red line? That's the Canadian average. You live here. I'm going here next week, and then I'm going there the week after. I'm not kidding. So we have funding to support people become aware of the overuse of sedatives for a reason. You are going to get 8 to 16 minutes more of getting to sleep faster, I should say, or 5 to 23 minutes more of sleep if you're taking sedatives in the first few weeks of taking them. People probably want more than just that. That may not be enough. So well done clinical trials show us that's what the average benefit of sleeping pills are, the effective prescription sleeping pills. They come along with a few other issues. So your risk of falls is increased 60%, of broken bones, 66%, hip fractures, 50 to 90% increased risk with taking sedatives. Most people don't know about the data that shows that they can affect the complications of viral illnesses like the flu. It's flu season, and we're just hearing that it might be a bad flu season. And also COVID complications are increased if you're currently taking certain sleeping pills, benzodiazepines and Z drugs, and have an infection, a viral infection like this. Probably what I hear is the biggest concern is their effect on memory. As we get older, we want to make sure we're sharp as a tack for as long as possible. And we know that the most commonly prescribed sleeping pills interfere with our ability to make memories. And so people will say, next day I woke up in a cloud and I went to work, or I went to do this, and I think back and I don't even know how I did it. So that's a big concern, because you don't want to be seen as, oh, there's some cognitive decline, when it's medication is inducing that. This one here about the BAC, do people know what BAC is? Blood alcohol content. You know, when you blow into when the police pull you over, they're measuring your blood alcohol content. Blood alcohol content of 0.08 or above is you lose your license for a year. And it's associated with driving impairment. So obviously we recommend against it. If you take Canada's most commonly prescribed sleeping pill, and 11 hours after you take it, you go driving, it's like you have a blood alcohol content in terms of your driving ability of 0.05 to 0.08. Most people don't know that. And these are really good studies that show that. And then the last thing is they're habit forming. What's the most common side effect that you get when you abruptly stop sleeping pills? Insomnia. You have a withdrawal symptom called insomnia. And that makes you feel like, oh, I still need this sleeping pill. So what is CBT-I? CBT-I is an effective behavioral and psychological intervention that's really a menu of effective sleep-enhancing components. The typical treatment is 6 to 8 weeks long. So think about it. 10 years of taking medication, 20 years of taking medication, no end in sight, no plan to end using medications like this, versus CBT-I for 6 to 8 weeks, learning different ways to improve your sleep such that you don't need sleeping pills and your insomnia is resolved. Most of the randomized trials indicate that insomnia in the long term is better off treated with CBT-I. And I'll show you some data really quickly in a moment. The number is about 70% of people who go through a program of CBT-I find it resolves their insomnia, even if they've had chronic insomnia. So the components are going to be something that you'll learn as you go through the program. And obviously today's not the amount of time that we can go through it, but I will talk about one of them, that first one there. What is this component called stimulus control or control? It is avoiding napping, setting and following the same time as a bedtime and as a rise time 7 days a week. If you feel sleepy before bedtime, what do? Do not let yourself fall asleep. If you don't feel sleepy at bedtime, what do? You don't go to bed. If when you do go to bed, you don't fall asleep within about 20 minutes without looking at the clock, it's a bit magic. You can do it though. Do not look at the clock and you think I've been lying here for about 20 minutes. You leave the bedroom and return when you're ready to fall asleep. Now, if it's 3 in the morning, what do? The same thing. If you've been lying awake in bed and it's 3 in the morning and you think it's been 20 minutes or so, leave the bedroom and come back when you're ready to fall asleep. You have to break that association of being in bed, being frustrated, having those racing thoughts. That's a challenge. That challenge can be met, and you can fix that association by doing this one step. Another step on there is called time in bed restriction therapy. Spend way less time in bed and then gradually extend it out over time. And that also helps with readjusting your relationship with your bed so that your brain is ready to shut off when you're going to bed. So that's just a couple of them. On our website, the mysleepwell.ca website, we have a variety of tools to help you be able to compare sleeping pills and CBT-I. We know that clinicians like this tool to have people open themselves up to maybe thinking about an alternative to sleeping pills, even if they've been on them for a long time. So this is something that I think clinicians may take note of. So how effective is this? I'm just going to mention that CBT-I is so well researched in the most robust types of clinical trials. So this is a study from people who have pain and insomnia, which is a lot of people who say, oh, I can't sleep because of my pain, because of the ringing in my ears, because of my digestive problems, because I have a cat in bed with me. Like, there's always a reason you have insomnia. But for whatever the reasons are, CBT-I has been studied really well. So from people who are teenagers to people well into their retirement years, whether you're pregnant or perimenopause or menopause, cancer, it's been studied in all of these subgroups of individuals. So I want to just let you know that this one study is just an example of studies. There's literally hundreds of good studies showing CBT-I to be effective. This is looking at 3 groups: CBT-I, or cognitive behavioral therapy for your pain, or you had to wait and you got nothing. And the people who have fibromyalgia, in this case, the best sleep outcomes were with CBT-I. There was some improvement with CBT for pain, and you can see not so great if you have to wait. I will say, I'm not going to show it, but the pain scores were better in the CBT-I group in the long term than in the pain cognitive behavioral therapy group. Very interesting. We see better depression outcomes with CBT-I in the long term as well. This is a study in older adults, people over 65, where we're comparing placebo, sleeping pill, and CBT-I. And what you notice is that when the treatment ends right here, the people who got CBT-I continue to have better sleep. So you do 6 to 8 weeks, your sleep gets better, and then you continue to know how to help yourself get a good night's sleep. So CBT-I is that 6 to 8 weeks of effort to learn the techniques, and then you continue to apply them afterwards. And you can see that the sleeping pills never met the same level of effectiveness. So what we're trying to do is really get people to rethink their overall approach to the management of insomnia. And this, we just published this about a couple of months ago, which is the step care model to insomnia management, where we're wanting people to take care of their own insomnia as a self-help approach. And there's lots of tools, and I'll refer to them in a moment, where you can do this on your own, so that the family doctors don't feel like people have to get their insomnia treated through me, and the best way I can do that is to continue to fill that prescription. We want to give everybody better options. So that's why Sleepwell was developed about 10 years ago, a little more than 10 years ago. It has 2 main objectives. One is to have people get better sleep through CBT-I treatment, and we want to reduce the overuse of sedatives wherever we're seeing the overuse of sedatives. So some of you may have seen our website. We're getting a lot of traffic at our website. So in the last month, there was over 14,000 people visiting the Sleepwell website. If you've been on the Sleepwell website, you'll have seen information about CBT-I. You'll have seen potentially Faye's story or George's story as a video to see what happened to both of them when they were able to come off of their sedatives. We have stories from healthcare providers as well, and it's in French and English. So it's available to people. I want you to know that, especially for clinicians, not everybody needs a full course of CBT-I. I work with a number of, I would say, primary care providers who are family doctors as well as pharmacists. When they give out information to get people familiar with CBT-I, we have this 10 tips. It's not sleep hygiene 10 tips, it's CBT-I's 10 tips to introduce you to the different components of CBT-I. Sometimes that's all people need. They don't need to go into that 6 to 8 week program. Follow your sleep using a sleep diary where you write down how your sleep went last night using a sleep diary. Take that back to your family doctor and say, do you see any patterns here that I can work with, that I can work on? And then the last one here is there is a sleep hygiene checklist. It's not the most important component of CBT-I. It probably is the least important for people who have chronic insomnia. Our website recommends cognitive behavioral therapy for insomnia programs. So there are programs that you can get through your reading. So you can get one of these books, which you go through the book and you learn the techniques. So a little bibliotherapy, if you will. And then there are digital options. This is US based, completely free. You can do the program all on your own. Some of them are not so free. If you know somebody in Australia and they're willing to give you their zip code, then you could join up with this way up. So there's some really good resources. Not all of them are available. We have this program that we will be testing. So if you're interested in joining us as a clinical trial, this is a workbook brand newly developed for the treatment of CBT-I. And I was just in Calgary and we were introducing it in Chinese to a group that's going to be using this booklet with small group learning about how to improve sleep. So we're trying to make what was something that you could only get through a therapist 20 years ago directly available to you as a self-help tool. We want to make sure our tools are effective, so that's why we're doing it as a clinical trial. There's information on the website about how do you safely come off sleeping pills, and that's going to have me transition into the next part of the discussion. Do not stop sleeping pills cold turkey. It usually is easier on you and more likely to be effective if you can do it gradually. So this is just an idea. Speak with your prescriber, speak with your pharmacist about coming up with a plan for that kind of thing. How do you join coming off sleeping pills with CBT-I? It's totally up to you. Coming off sleeping pills can take a long time. You could do a CBT-I program over 6 weeks at the start, or you could wait till the middle, or you could go near the end, or you could wait until you're completely off sleeping pills. And if you see that you have an insomnia problem, you can do CBT-I then. So there's no magic time to connect when you use CBT-I as you're trying to come off of sleeping pills. And so we did a study that's called YAWNS NB, because we did it in New Brunswick, Your Answers When Needing Sleep in New Brunswick. We mailed people this as a package. So you see there's two booklets here. One is how to stop sleeping pills, and the other is how to get your sleep back. Everybody in our study was taking sleeping pills. The average duration of time was 11 years of taking sleeping pills. And the average age of the person was 72 coming into our study, ranged between 65 and into the 90s for the people who received this package, or they received no package, or they received a package that had been studied in Quebec and was shown to be beneficial for helping people reduce their use of sedatives. So 565 people came into the study, and this is what they received, a nice little cover letter. Andrea, who you met early, was involved in how we made these booklets include what we call behavior change techniques. So we know that smoking's bad, right? But it's hard to, stop smoking. You need to be convinced. So you know how they put those ugly pictures on the packages? That's one example of a behavior change technique. There's actually 93 different behavior change techniques, and Andrea was able to help us figure out how to include 27 of them. So you're not so comfortable with long-term use of sleeping pills, and you're excited about learning about CBT-I and using that. So it's not just an information package, it's an information package with kind of behind the scenes techniques to try to activate you, motivate you, and give you the ability to make the changes that are in the healthy direction. So these booklets we can talk about afterwards if you're interested in having a look at them. But this is just giving you some insights as to what people were able to see. Does sending booklets directly in the mail to people who are taking sleeping pills long-term actually work? I would have said no. Probably not. I don't think you can substitute a healthcare provider with a booklet, but in this case, actually, it worked unbelievably well. 1 in 4 people who received the Sleepwell package were completely stopped their sleeping pills and didn't switch to any other kinds of sleeping pills at 6 months. We didn't do anything else. We didn't train doctors in New Brunswick about this. We didn't train pharmacists about this. We sent a package out, and then we shut the lights off for 6 months, and we called people back up and said, how are you doing? And we measured their use of sleeping pills. We have new data that I can talk about today, I couldn't talk about yesterday because of an embargo, that said the sleeping pill use reduced even after the study was over. So I'm happy to be able to say it wasn't just because they were in the study that it was working, it was because people really found it effective to help them come off of sleeping pills. The one thing we didn't know what we would find is if we help people reduce and stop sleeping pills, is it going to cause problems with their sleep? And what we found out is if you tell people about CBT-I, it seems to actually help them get off sleeping pills and improve their sleep. So the Sleepwell package was associated with an improvement in sleep. The other package that was helpful to get people off sleeping pills didn't improve sleep. So this is why people are saying, David, if you want to go around and tell people about it, we would support you in doing that, because this helps people reduce their dependence on sleeping pills and also get a better night's sleep. So what have we learned? And just before we pass this over to Sam, sedatives are overused, especially in this part of the country, and really CBT-I is underused. CBT-I is clearly the preferred option. It's more effective long-term, and it's a short-term intervention that people can do. But CBT-I awareness is something we need to increase, and we can overcome that with events like this. And we learned through the YAWNS NB study that directly sharing the information with the individuals who are having the sleep problems and using sleeping pills long-term is effective. They go to their family doctor and say, I got these booklets, what can we do? Can you help me reduce my use? Or they go to their pharmacist and say, maybe we could start talking about how I could cut down on these kind of things. And I want to just, before we go to Sam, just ask you, can you read that? So we want to make sure that this information is accessible. People in Iceland learned about our study here that was done in New Brunswick, and they said, we'll take those and we'll send them around the country. So Andrea and I were in Iceland this summer. I went into a walk-in clinic, and there they were. So they made 20,000 copies, sent them to all the clinics across Iceland, and sent them to all the pharmacies across Iceland. So that's one way to do it. Another way is the way we did it, which is we sent it directly to the people who are taking the medications. So we'll find out in a few months if the Icelandic approach actually reduced the high use of sedatives in Iceland. So what's next? We're trying to get people to talk with us, especially government people, clinicians and otherwise, about can we develop some sort of patient, public, clinician-oriented program to raise awareness and provide the tools to help people start to transition away from sleeping pills to CBT-I. And with that, you're totally set up, Sam.
Yeah, so I'm Sam Hickcox. I'm originally trained as a family physician, and I would say definitely my first encounters struggling with patients with insomnia, and particularly primary insomnia, happened in my family practice. I've worked in a number of other different specific clinical areas, but I'm a trained psychotherapist, and I'm essentially a specialist in caring for people who live with various substance use disorders or addiction. And I'm also direct an organization that has an interest in training healthcare providers to engage in better evidence-based healthcare in the realms of pain care and addiction care. Primarily, a lot of the focus of the education that we provide is around looking at alternatives to pills that are used sometimes to treat and are very effective in the short run at treating anxiety and treating pain. So benzodiazepines and opioids, for example. And you can't just tell physicians to de-prescribe people and take them off of medications that they've been on for a long time. You have to look at what are the other ways that people actually can manage pain or manage anxiety. And the same holds true for insomnia, particularly what I call primary insomnia. I don't know if that's an outdated term now.
It is.
I'm not a sleep specialist. Okay, excellent, good. So it would be sort of the notion of insomnia that has been built and developed over a long period of time through conditioning, exactly the way that Dr. Gardner has outlined. So, in fact, our organization is looking to train more family physicians in how to do CBT-I, and in particular, the application of CBT-I into their practice. So in other words, I'm kind of like the converted here, you know what I'm saying? So it's a bit of a cheat, right, to have me.
We didn't convert you through this presentation.
I'm afraid, no, but there's always something to learn. But as a family physician, I would definitely say that first, what's your first question?
All right.
You had a bunch, and
So
how
how
like to
often
be a family physician?
how often does insomnia come up when people visit their doctor? And the follow-up is, how do people manage their insomnia all on their own? What have you seen and heard?
Yeah, and I would say that what I have seen and heard seems to correlate with some data that we have, Canadian data, sort of larger survey done of Canadian family physicians across the country that was just published last year. That's what that sheaf of papers is.
Thanks.
And essentially, it's first and foremost is that we know that insomnia is a common occurrence, and I've heard estimates between 25 to 50% of adults, and we know that it gets more prevalent as a concern for individuals the older they get, and we have an aging population across Canada, and that definitely holds true for Nova Scotia. And so it wouldn't be uncommon for me to see, say, between 10 and 20 people in a full-time family practice every week who are, working on insomnia or through insomnia. Now, that's not necessarily 10 or 20 brand new people every week, but if we're looking at a practice of like 3,000 to 5,000 patients in a full-time family practice, that's kind of the rate. And probably something like 7 to 13%, and I would say you're probably about 1 in 10 of my patients coming in, that's their primary reason for coming in, is that they what they say to me is that they're concerned about sleep. And yes, absolutely. And something that's not often asked about, I think, is what have you done so far to manage insomnia, right? And what people do tend to do is gravitate towards a couple of behaviors that are intended to reduce their suffering that is associated with living with insomnia. So first and foremost, sleeping in when they can, and really trying hard to get to sleep, and describing the experience of lying awake in bed at night for hours at a time, right? Looking at the ceiling, if not at the clock. In addition, they will turn to over-the-counter medications, which are designed to treat other conditions, other symptoms like nausea, so Gravol, right? Or allergic type of reactions using Benadryl, which is actually, these are both medications that the molecules are very similar to each other, and they work, they have an effect on our histamine system, and so they're antihistamines, and they basically make you drowsy by virtue of being an antihistamine. And people will turn to melatonin and use melatonin. Often they'll take it at night just when they're going to bed, hoping that actually works as a sedative to put them to sleep. So, and then as well, not often asked about, but it's a very significant strategy that people will engage in specifically, which is to either consume cannabis or to drink alcohol, or both, right? And something that's really important to know is family doctors don't frequently, when they start people, say, on a prescribed medication to help with insomnia, it's very common for patients to continue to use over-the-counter sedatives as well and not stop them. And nobody kind of asks about it or thinks about it much.
Yeah.
So,
Yeah. So there's usually a long story of trying to get a good night's sleep before somebody comes in to the family doctor.
Absolutely. Yeah. Absolutely. Yeah.
The challenges of treating insomnia. I've got a couple of, specific questions, but just in general, what do you think are the challenges from your experience or others?
Yeah. I mean, I think that, I'm hopeful that medical education is changing, and that we're always sort of trying to adapt what we teach physicians with respect to conditions like insomnia. So, in other words, to do more evidence-informed or evidence-based care. And you mentioned Choosing Wisely, which is an intervention that is in Canada designed to really broadly educate particularly busy family physicians with respect to certain very core things that if you do this or don't do this, it's better for patients from a prescribing practice, or anyway, other aspects of care. But when I went through training, which was 8,000 years ago, it was So I finished my family medicine residency training. So I was a kind of full-fledged family doctor in 2007, right? So at that time, we did not have any training regarding how insomnia actually developed, how it actually works as something that people actually, through very rational, logical responses to sleeplessness, they change their thoughts and their emotions and their behaviors around sleep that actually creates more sleeplessness, right? And that cycle. So you kind of outline that cycle. I often sort of, I've given some talks that are slightly dumbed down versions of this, but for example, a picture of a bed that's got all the messed up sheets and so on. And, the person who's going to bed living with insomnia, it's sort of like a task, right? Yeah. This deflating task. If only it was more exhausting, that would be helpful, right? But, so it's sort of this thing you have to achieve, right? And of course, this thing you're monitoring, keeping your finger on the pulse and watching. And so the tension involved with that, the kind of expectations, the pressure you're putting on yourself, which I think, you've outlined well. That's like, we had no education around that. Yeah. None. No idea that that's what was happening. I can tell you right now, like when patients I don't have to take a big sleep history for patients to already give me clues, such as sleeping in or spending hours in bed, to know, aha, we've got an opportunity here, we've got somewhere to actually intervene without even having to do full-fledged CBT-I, right?
Yeah.
And the opportunity is to give people tools that they can actually put into practice that actually have been shown to be helpful. The other thing is that, if you look at sort of what we're expected, basically, we see people suffering, and our job is to relieve suffering, right? And we're empathetic, and we want to help people.
Yep.
And we have 8 minutes with a patient, and that patient has already a bunch of health issues that are either making worse sleeplessness, or they are exacerbated or a result of sleeplessness, obesity, cardiovascular disease, depression, diabetes. It goes on and on and on. And so suddenly we have someone in there 8 minutes, they've got 9 issues, right? I'm trying to get them on Ozempic, of course. Everybody needs to get on Ozempic, right? We all do. So, it's like, often we're thinking, okay, yeah, that's the thing, but we got too many other things to think about, right? So that competing priority, that's very important. We don't always have time to screen people for all the things that might be related to insomnia, right? That we should be thinking about, like cardiovascular disease and diabetes, right?
Yeah.
We often don't ask people about their drinking, right? Their alcohol consumption, which even in the absence of addiction is tremendously disruptive with respect to our sleep, the quality of our sleep and the quantity. We end up also being told, this is what you need to do. You have to rule out obstructive sleep apnea, restless leg syndrome, chronic pain, overnight peeing overnight, shortness of breath, maybe circadian rhythm disorders, childhood trauma or chaotic home environments, even in the absence of PTSD, medications like steroids, opioids, stimulants, antidepressants, psychiatric disorders. We're supposed to evaluate and do a complete sleep history. And I've got this list I'm not going to read, but this is what's recommended, right? Yeah. This is not realistic, right, for us to do, to be frank. It's not for us. We're well paid. Don't get me wrong. This is expensive. But I think it's important to know that, it can feel overwhelming, especially in the face of competing priorities. Most family doctors actually now know that sleeping pills don't really work that well in the long run and that there are risks with them. But sometimes we just need to give someone something that gives them short-term relief. And we've got a full waiting room, and we got to get that person out of the office. And it's not about, I don't care, but it's just more that pressure, right? So it's easier to prescribe medications and get some rapid results sometimes. And especially when people are coming to you, they're in crisis, right? Maybe they've got, some personal crisis in their life that's led them to be acutely sleepless. And for me to take 35, 45 minutes to really sit down with that person, give them support, emotional support, counseling, and then to sort of go through evidence-based management, it's hard not to pull out the prescription pad. Yeah. The other thing that happens is we have what are called legacy patients. A lot of family physicians and young ones who are coming to practice who are well educated by people like Dr. Gardner, and they're receiving a whole cohort of patients who have been on medications for 11, 12, 15, 20 years, and the doses have been gradually going up. And those patients are often very, very resistant to making changes because they have also been conditioned by, rather than tapering, suddenly stopping, or I went without my Zopiclone for 2 days and it was the worst time in my life. I'm never doing that again, and clearly I need these medications. Yeah. So they've also reinforced this idea that this is what I need to just get through the day, which in the short run is true.
When we talk to people about potentially coming off, the wall is up as quick as the sentence is finished. Yeah. The wall is up. We're not talking about that. And that's why we thought if we send the information directly to them and they warm up to it gradually over time and then they go see you, maybe they'll have a different approach to it.
Yeah, I think it's a great strategy. It's kind of like this. If you go to the family doctor and say, look, or the family doctor, between you and the family doctor, you determine that, you're overweight, you have high cholesterol, you smoke cigarettes, and you don't exercise enough, and your diet is this or that. You don't really need to convince people that what really, won't work, or watching more TV or eating more Doritos, that we all know about, basically about cardiovascular fitness. We should eat well, and we kind of have a general sense of what that means, with exceptions. And the same with exercise, right? We have a general sense that those are good things for our hearts, et cetera. And we don't really have that same level of education or understanding in the public about sleep and how sleeplessness gets developed, and really what works and doesn't work. So that's part of why I think these kind of campaigns are absolutely essential. And, we've had to do the same thing with opioids and pain, right? Opioids are not bad. They're just an agent that's useful for pain in certain contexts and for certain periods of time. The other thing that one of the things to add is that we don't think about how short-term insomnia can turn into long-term chronic insomnia, and what can we do to prevent it, right? And one of the things that we can do to prevent it is to to commiserate, to validate people's suffering. If we feel the need to prescribe medications, keep it really short, right? And try to work with patients over time to normalize and reassure that it's okay, it's suffering, and that is not okay, but you will be medically okay if you go sometime without sleeping well. And that's sort of the starting to begin to give information that informs CBT-I, which is that the training that people need to do involves being able to tolerate some periods of sleepiness during the day because they haven't had a good night's sleep the night before.
I work with a family doctor in Kingston, and she's giving people the sleep diary as the intervention. Come back and we'll talk about it. So you're being heard and we're looking into it.
Absolutely.
But it's not we're giving you a sleeping pill as a quick solution for it.
Yeah, absolutely. I mean, I think that what our advantage is, the power that we have is we can see patients over a long period of time, right? Cradle to grave, ideally. We always have the opportunity, we have relationship. There's trust, there's caring, there's concern. You can set the stage for making changes in how you manage your sleep, and changes in medications, and starting to lower medications. There's this word deprescribing, or we talk about tapering down. And the family physician is actually well positioned to support that person in reducing and hopefully eventually eliminating medications which really aren't helpful and actually are counterproductive. And that is to send the following message first and foremost. This is a problem. You are suffering. Your suffering is valid. This is not your fault. It's something that happens over time to people. And there's a journey to go on to reduce and then eventually eliminate these insomnia medications. That's a journey I'm going to go on with you. We're going to do this together, and I'm not going anywhere. And that's actually a message that a family physician can credibly give to their patient. That is the foundation upon which then the training can begin. Just the same way, if you go to a personal trainer because you've been a couch potato for 10 years and you need to get in shape, you want someone that's going to be on that journey with you. Right.
Yeah. Which kind of answers that question, but maybe you have other things around, like, what do you see us going forward? Like,
well, this is
big picture, or right in with an individual patient.
So my experience is this, is that actually learning how insomnia works, that we actually train ourselves. Like if we have a bad night's sleep or a few bad nights sleep, and maybe we've been given medications, we've maybe even been told by someone like me, we need to get your insomnia treated because otherwise you're going to have an increased risk of heart attacks and strokes in the future. Like these all generate distress, right? And that distress is what ultimately feeds the behaviors and the thoughts and the emotions that actually keep people awake for a long time. So understanding that, if I can understand it, anybody can. That's how I feel. Like it wasn't that hard I didn't have to be a psychotherapist to understand how that conditioning works. Right. And then from there, when I meet with patients, whether or not I'm prescribing, whether I'm continuing to prescribe from someone else, whether, whatever the situation is, even if it's all of these other causes or things that are contributing, like for example, maybe they have depression and so on. I know that I will benefit them if I can even identify one or two things that are really from CBT-I and help to support patients in those. And so, for example, I'm a big fan of the after 20 minutes, get up, get out of the room if you can, like depends on the person's living situation, but away from the bed, go somewhere else, do something that's not too stimulating, no screens, but like reading a book. I sometimes recommend maybe cleaning out your refrigerator, something that's boring, and listen, I struggled with insomnia, and I was like in residency.
Fridge is really clean, is that what you're telling me?
Sorry, residency, I was like, we have a terrible sleep situation, so I was prescribed by my family doctor trazodone and zopiclone, and I had to go through a process of weaning those off. My wife, who's a family doctor, has just completed a 1-year taper, so she was like, "Yeah, you tell him." So, and it's like, this is one of the things I said to my wife, isn't it great? Like your sleep's just as crappy as it used to be when you were on zopiclone, right? She says her sleep's better than it was. And I think it is actually, but and then really wait till you're tired and you're like, but it's 2 a.m. Oh my God. And I need to sleep because blah, 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 right? It's like, that's okay. People are down cleaning their fridge or reading a book or whatever, and then you get sleepy, and then you're going to go back up. And if you see the bed, you might get unsleepy again. That's okay. Just take a breath and calmly go back downstairs. Within a couple of days, people have reconditioned themselves. And, part of it is they got to get up in the morning at the same time. Sometimes we'll leverage things like melatonin off-label to sort of help with circadian rhythm associated with, but I mean, I'm sort of starting to hear some people talk about that, about risks of melatonin. I don't know if you, like, I really haven't been able to find any evidence.
Bigger message about melatonin is it's effective for sleep problems that are not insomnia.
Yeah, that's right. That's right.
So we've got really good clinical trials in people who have run-of-the-mill insomnia where it is as good as placebo. The placebo effect is really strong, and it makes people think the melatonin effect is strong. So when you do a proper trial, you see them being equal. But in studies where you have a sleep phase shift disorder, which some people have, that's where melatonin really works out. So people have said, well, if it works there for that sleep problem, let's try it here. And then marketing takes over.
That's right.
And we don't actually have great data to know for sure if it's got that harm or that harm or that harm. Just our system of being able to identify those harms and say it's a causal relationship is really tough.
Yeah, it's because you're also looking at a population of people who have, if they're having trouble sleep, then they're more likely to have heart issues. Anyway. But I'll just say this is that, like, the way I would use it in this situation would be if someone is in the habit of lying awake in bed till 3 a.m., sleeping until 11 p.m. or till 11 a.m. And then we're going to start doing other things like related to CBT-I. We get them to set a wake up time. They decide what it is. They could gradually move it back. But let's say they get to 8 a.m. I'll get them to take melatonin at 8 p.m. the night before to just support their circadian rhythm. But that's not a long-term thing. That might be for like 2 days, 3 days, right? And I do that in the setting of people who've been taking it at night to try to get to sleep, right? So I say, you know, what you should do is look at when do you want to wake up? They tell me, and then I'm like, take it 12 hours ahead of time. Really? But won't I be? They're all worried they're going to like crash their cars and be sedated. It's just doesn't work, right?
It's not a sedative.
No, that probably doesn't work for insomnia.
What Sam is basically saying is how it gets used for jet lag, and it's effective for jet lag. You're doing flightless jet lag treatment is basically what you're doing. And that only goes for a few days.
And honestly, if it's a placebo, it just makes people tolerate when the alarm goes out at 8 a.m., they're more likely to get up. And that supports them with this process. So
we just want to formally say we're into Q&A mode.
I'll just say, I'll just summarize by saying that I've been shocked at how easy it is for me to find one or two things to work on with patients that are actually grounded in evidence. And that actually, regardless of what we do with meds or on the journey of getting off of meds, is helpful for people, and people are receptive and they want that. And it doesn't, you can do that within that 8-minute time slot. And it doesn't really matter if they're sleepless because they've conditioned themselves, or they have depression or a trauma history or chronic pain. And I teach a lot around chronic pain. We teach sleep hygiene because good sleep medicine, because if you actually get your sleep improved, your pain gets better. That's really clear. And we know that a lot of the meds that we prescribe for sleep actually change people, like the amount of depth of sleep that people are in. There's a concept of sleep architecture, different levels of sleep that you're in, and they keep people out of the deeper levels, and that's been associated with more pain, actually. So pain management includes getting off of Z drugs, benzos, alcohol, because alcohol does the same thing.
All right, so we're going to go to Andrea's got a question.
Yeah, so there's been quite a few questions coming online, so maybe we'll grab one from the online audience first. But it does relate to the point that you're just talking about. I'm kind of grouping several of the questions together, and folks in the room, are folks familiar with medications like trazodone, amitriptyline? So you may have heard of these medications. I think it's, the answer probably won't be a surprise by now, but some folks are asking about those, and also cannabis. And I know, Sam, you had touched on that as well. So I don't know if both of you want to just give a quick perspective on that.
That'd be great. Okay.
My short answer is, this is really common when I do a talk on, we're trying to reduce the use of medications. People sneak up to me and say, but what's the best one? Don't tell everybody else. There isn't a best one. There is a better approach, and it's not a substance and it's not a medication. It is what we talked about. It's CBT-I. So I know people have individual questions about individual drugs, and my answer will actually sound very much like what I just said.
Right back at you. Nothing to add. Yeah, we use them. We prescribe them. Sometimes we have to negotiate with patients to get off of things that we know have more harm, but they still aren't ready to stop taking medications. Sure, all of that but it's all about negotiating for things that are somewhat less harmful, but still are not really ideal. Ultimately, that's that's what we're doing in those circumstances.
Okay, we got a question in the room we're going to take.
Yes, the CBT-I actually help an elderly person feel refreshed the next day.
So No treatment has a guarantee, but what I can say is it's been shown to be effective in older adults, just as it's been shown to be effective in all sorts of other groups of individuals or groups of patients. So there's a lot of research on older adults using CBT-I. And the daytime refreshed question specifically, that is going to be unbelievably yes for some people and not so much for other people. But the average is, it certainly makes me feel better during the day. That's the average.
Yeah. Yeah, I would agree. In the long run, CBT-I is going to lead to less daytime sleepiness than the long-term use of any medication that's used to help with sleep.
There have been a few questions about napping and the impact on sleep. So rather than get into specific nap times that folks have put in the chat, I'll just ask, do you want to just provide a few comments on napping?
Sure. So I did talk a little bit about napping. So if you don't have insomnia and you nap, it's not an issue. If you have insomnia and you're treating insomnia, there's really strong evidence to say, can you minimize or avoid napping at all, if possible? So I tend to say, if napping is necessary for your safety, as in you're so tired during the day and you have to drive or something along those lines, then you may need a nap. But if it's a habit, can you get out of the habit so you're not stealing from your nighttime sleep? Napping is a bigger issue with sleep apnea than it is with insomnia. So we have to think sometimes when people are saying, I can't not nap, maybe there's other investigations that are needed as well.
Yeah, well, it's interesting. I didn't know that about that difference between those two. Yeah, I again, kind of like the questions about trazodone or other medications that maybe aren't as bad. And, when we're negotiating with people, and trying to sort of find a plan that in the short run, like a small, measurable, achievable goal for someone, and they're not ready or prepared to eliminate napping, right? We try to really put some quantifiable sort of parameters around the napping in terms of how long and what time of day you nap, and get people to work towards a goal. And that goal might be no napping after 3 p.m. or no napping after noon or no naps beyond 20 minutes, right? It's really the sky's the limit, honestly. But the idea is to try to create some kind of goal that is, at least in the short run, a person feels reasonably confident that they can do. Instead of it being like someone like me or David, like keenly saying, this, you should be perfect, right? And do all these perfect things. Isn't this great? Come back and see me in a month. Of course, it just can set people up for failure, right? So the science of like getting to the place, that ideal place of no napping during the day, it takes time, right? And so the first thing I would say is that I would agree completely, and the science is really clear around napping, reducing that sleep pressure. But if you can move it towards an earlier time of the day, if you can reduce the amount, if that's what you need to do for it to be tolerable, I would don't feel bad about it. Don't feel guilty about it. This is going to make you feel worse. You'll be lying in bed at night, guilty about your nap. Right? and actually, that does really happen, right? People, I know I should be doing sleep hygiene. It's like, oh gosh, it can become the thing that keeps you awake, ironically, right? So, just everyone, just kind of try to be gentle.
Okay, so obviously the gold standard is the CBT-I. And so I've have a long history of terrible sleep. And so I really do all the things. Like example, yesterday, I got up first thing in the morning. I go outside. I don't wear my glasses because I have the protective. I get the morning sunlight. I know that that's a good thing. I do that often. I went to a yoga class in the morning. I do yoga really regularly, which includes breathing exercises. Yesterday I went for a long walk, 55 minutes. Then I went for another short one because my daughter wanted to go. I don't nap in the afternoon. I took an Epsom salts bath last night and I went to bed at 10. I woke up at 12:40. I was awake till 3 in the morning, and I'm trying to stay awake here right now. And that's what my days are like. I could teach what you're supposed to do.
So the what you described in many ways are that first sort of step that most people take called sleep hygiene. Do all the things that are on the sleep hygiene list. And people who have had insomnia for years say, I've done that, I've done all of these things, and I'm still struggling. So then the next step is to do some of the more difficult things, like, did you get up in the middle of the night for a week after laying awake for 20 minutes? Did you leave your bedroom? And then did you compress your time of sleep? So what CBT-I does, usually in the second week or the third week, is it says, how long were you sleeping last week based on your sleep diary? And you say, well, I was in bed for 8 hours and I was asleep for 6 hours. Next week, you get to be in bed for 6 hours. And so you compress your time in bed.
Yeah.
And then with compression comes discomfort, but then you get the rewards of it. Something called your sleep efficiency starts to go up. And as it goes up, your time in bed gets to go longer and longer.
Yeah.
So that's the behavioral component of it. And then the cognitive component will come in. And what are you doing with your thoughts during that time? Are your thoughts helpful? Saying you're amazing, you're able to stay up all night long, this is fantastic? Or are you trying your best to get to sleep? Because if you're working hard to get to sleep, the psychologist will say, we need you to stop trying.
Yeah. It sounds
Yeah.
like
Counterintuitive.
impossible.
Yeah.
It's like there's an old riddle, like don't think of a monkey. What's the first thing? Like, how do you deal? But it is possible to sort of, with guidance, right, create a plan that works, that actually challenges those ideas, right? But it does take time, and sometimes it needs to be tailored specifically, right, to your specific situation when you've kind of tried some general things and they haven't been working, right?
So I don't know if what I've said makes you feel like, well, I guess there's a couple of new techniques I could try. But it might be just saying, okay, I will go to the website, I will find a CBT-I program, and I will do it for 6 weeks or for 8 weeks.
Yeah.
I can't guarantee if it's going to work or not, but it might be that you need to add all the components together and come out in the end with all components as part of your overall strategy for improving your sleep.